Not least, we have Dr. Henry Shugart. Shugart? Shugart, okay. Board-certified internal medicine physician with Carolina Medical Affiliates. His areas of treatment are general medicine, adult health, wellness prevention. Dr. Shugart comes to us from Winston-Salem, North Carolina, and he completed his undergrad degree from Virginia Tech. He's a graduate of Bowman Gray School of Medicine at Wake Forest University. He completed his internship and residency in internal medicine at NUSC in Charleston, and he has received numerous awards in biochemistry and for his medical research. Please help me welcome Dr. Henry Shugart.
How we doing? Oh, that's loud. Can I put this somewhere? Is it gonna be too loud? Or? Whoops. I'll just walk around if that's okay. This is kind of informal. Ms. Holt asked me to speak. I said, why don't we talk about the political side of medicine, how it's affecting my practice as an intern, so I appreciate the invite and opportunity. I'm going to mirror a lot of what these other doctors have told you, because what you're going to see is that we're kind of frustrated, especially me being a physician in traditional delivery of healthcare. It's a very frustrating way to practice medicine. I want to get into that a little bit. But part of my lecture, I say lecture, my talk, y'all afraid because I'm going to be up there for 45 minutes. No, I'm trying to keep it quick. But is how did we get here? How did that problem evolve? What happened? And the first big point is what y'all alluded to earlier, what you stated, was that the big problem is that we receive money, I receive money as a physician, my paycheck is paid by the insurance company and by the government. It's not paid by the patients. That's a big problem. And that's a big issue and influences our decision. When you go back to the old days, previously, when you went to the doctor, then you paid the doctor cash for your service. You could negotiate, you could decide if it was worth it or not. And a lot of people may or may not have had catastrophic coverage, which was helpful in case of, God forbid, something bad happened. But most of it was done in the office, and you could decide what was fair and what wasn't fair. But then in 1973, there was an HMO Act that was passed that encouraged employers of a particular size to provide health care, offer health care benefits to their employees. And what that did was change the landscape dramatically, because now, as a collective public, we thought of employment equating to healthcare and healthcare opportunity. Well, the converse of that is true as well. If you didn't have a job, guess what? You got no healthcare, or at least you're out on the sidewalk trying to figure out how you're going to get healthy, or if you're going to have particular things paid for. And that's a problem, and we're still dealing with that. So when that came through, the complexities in managing patients, because there are different opportunities for people to have different plans, it got more and more complex. So doctors had to hire more and more staff. Currently in our office, we've got 15 providers and we've got almost 100 employees. And the majority of them are dealing with insurance companies, and collections and receivables. And it's got nothing to do with delivering healthcare. I'm sorry to say it, absolutely nothing. I'm going to quote one of my physician mentors when I was in school. He was a family practice doctor, and not to get too much demographic data out, but he was practicing up in Shelby, North Carolina, not too far from here. He practiced for 40 years, and he said when he started, it was him, it was his nurse that helped him out, assist him, and it was the lady up front that managed the waiting room and took phone calls, scheduled appointments. And then he said 35 years later, when he was thinking about retiring, it was him, same nurse, same lady up front, and 9 other people to help deal with insurance companies. So what happens with that? Well, you know, it's a business. So by definition, costs have got to go up. When you're getting service from somebody and they've got to employ and provide benefits now for these 9 other employees, the costs have got to go up. What does that do to healthcare? It's got nothing to do with the type of quality of service you receive. So higher prices goes up, and then you add more expensive technologies, medications, more specialized services, insurance costs. Now we know the cost of medical care is going higher and higher. And unfortunately, a lot of people have been left behind, unable to get quality health care. And in effect, as the business of health care has become more and more complex, the presumed benefactor of all this, the patient, has been left behind. That's where we are right now. What happens when we get that situation is the government ramps up, and you can say it's very honorable and noble, but what does the government do to fix things? Well, it starts entitlement programs. We want people to have quality health care. We want people to have access. So we're going to create systems. Now you have Medicare, Medicaid, disabilities, blah, blah, blah. It increases costs, complexity, and efficiencies. In an effort now that costs are going sky high, we've got to mandate, I hate to use that word in this context, but you have to regulate the decisions that are being made to control the cost. It directly impacts the care of the patient. So let me give you a couple of quick examples that just frustrate me as a primary care physician. I had a lady come in that was 88 years old. Her main medical issue was that she had hypertension. And she'd been controlled by this one medicine for about 6 years. No problems, still good. She'd come in once a year, we'd check on it. But then a problem happened. Her formulary, they made a decision that this medication was too expensive. They switched to another medication, and they would not fill that medicine. So she came to me and said, what do I do? And I've never had a problem with it. I'm controlled. Everything's good. So what do I have to do? Well, I got on the phone. I was on hold for about 20 minutes. I finally get on the call with somebody that I'm not the elitist dog, because I'm certainly not the smartest person in the room. But this is somebody that does not have the education and clinical expertise to make these decisions. And my debate with this person was that, lady's doing fine, there's not a problem, let's just continue this medication. And they said, no, we need to try her on this other medication at 88 years old. And if she fails, I'm quoting, if she fails that medication, then we will allow her to go back on her medication. I said, well, let's define failure. That means her blood pressure goes up, she perhaps has a stroke. So when she has a stroke, I'm going to call you back and I'm going to say, hey, hooray, she's failed. Now can we go back to the medicine? But it's too late. It's too late. Now how does that save any kind of money? It doesn't. Now we average every Monday, today was a busy Monday, 600 plus phone calls a day to our office. Very busy. And if each and every one of those we have to spend 30 to 40 minutes on the phone trying to pre-approve medications or studies, there's absolutely no time. There's no time for all this. And I can give you more and more examples about trying to pre-approve MRIs and have unauthorized prescriptions and chemotherapies, all kinds of crazy stuff that we have to go through to get approved for our patients. And we do it. And one other thing I'm going to throw in there is this whole electronic medical records. If y'all have been to the doctor, you see us walk around with these cool tablets and the patients are impressed. I hate it. I really hate it. The first year that we went to electronic medical records, we have to take all the data from the paper chart and put it in the computer chart. How does that happen? Well, I'll tell you how it happened. I went in every weekend for about 12 hours a day and sat there and typed and make sure that the records that I thought were important for all my patients would be correctly entered into the computer. Because once it's in the computer, it's going to be erroneous if it's not correct. Now, they told us when we went on to electronic medical records that it would only take 2 to 5 minutes extra a patient a day to document. Well, if I say on a slow day, I say 20 patients, so that's an extra hour and a half a day that I'm sitting here typing on the records. In fact, where does that time come from? Because I want to go home and see my family. So it's going to come from the interactions with the patients. So that's 2 to 5 minutes less that I get to spend with the patients trying to figure out what your concerns are and address what you want me to address. And an increased cost, oh, by the way, because we recently had to replace 65 computers in an office, and it costs about $1,000 a computer, and that's saving money and making healthcare more efficient. I don't buy it. I don't see it. So obviously I'm throwing my biases in there. Now, let me throw some of the other frustration we're having as primary care physicians. Over the last 10 years, and this is not the woe is me segment, okay, but I'm just telling you the facts. Over the last 10 years, on average, reimbursement per visit for a primary care physician has gone down by about 20+%. So that's every time I walk into a room and see a patient, I get paid about 1/5 of what I was about 8 years ago. And that's with increased cost. So how do we make up the difference with our increased overhead and our decreased reimbursement? And the answer is volume. Okay, alluding to what y'all have mentioned, I see more and more patients every day. If I'm going to maintain where my income is, and again, y'all think, oh, doctors make so much money, it's very different from what you think it might be. But I've got to pay overhead, I've got to pay for my employee salaries and benefits, and all that is going up. So I've got to see more and more patients. And every conversation we're having in our practice right now is trying to figure out how we can get more patients through the door. That's not what I want to do as a physician. And that's the frustration that's being spread around the United States of America right now. And that's the problem you're going to see. When we try to cut the costs of healthcare, the costs are going up. And so what they did is they said, well, we're going to start capitating. But what does that do? When you limit costs and reimbursements to physicians, you actually increase the cost of the whole system. Because more ER visits, less time with the patients. If I'm sitting there and I'm saying, well, I've got my next patient in, I've got this problem, it's going to take a good 15 minutes, I don't have it, here's a prescription, here's a test, let's refer you to the specialist, more and more and more cost. So by and large, when you reduce the cost to the primary care physicians, again, I'm biased, you're actually increasing the cost, and I think your graphs show that directly. You're increasing the cost burden to the system. Access goes down, costs go up, and people are frustrated. I mean, I hope you're happy. You don't have to answer with the care that physician provides, but it's not going to get better or get to Christ. So honestly, when Obama was elected, now we're getting political, but this is my bias. I'm not trying to offend anybody. But when Obama was elected, physicians, by and large, were excited because he was going to tackle healthcare reform. Finally, somebody was going to wrestle this monster down. And we had some very specific thoughts about how we change healthcare and how we improve it. Number one, tort reform, talking about lawyers and lawsuits. That's huge. And I never thought it was such a big deal, but I did a little inpatient or in-house survey for myself, thinking about the number of tests that I ordered that I really didn't feel like I needed to, but I did just to cover my butt. Okay? Within a couple weeks' time, I stopped because the amount of tests I was ordering just for that purpose was ridiculous. And that's primary care physician. We are trained to use our brain, not so much testing. If you go to the emergency room, back me up on this, everybody goes to the emergency room, gets a CT scan, they get labs, they get everything. And what does that do to improve the care? Nothing. Nothing. But costs go up, and it saves them some liability because if they go in front of a judge and put their hand on a Bible, did you order a CT? Yes, I did. Did you check an MRI? Yes, I did. You know, the outcome, we don't care about that, but you did all the tests you're supposed to do, so you must be a good doctor, right? It's got nothing to do with that. The other things we wanted were fraud and waste reduction. The amount of money spent fraudulently and wasteful in healthcare is just ridiculous. Now, I will say they've done a good job on that, and they've approached that and done a good job on reducing fraud and waste. We still have lots more to try to get into, but at least we're making inroads to that. The dysregulation, not the over-regulation, but the dysregulation of the insurance industry. We want everybody to go and say, hey, you know what, I just need a basic policy, I don't want to spend a lot of money, and I want it to be cheap. But we're going the other direction. As we notice, premiums and everybody's feeling for insurance are going up, going through the roof. And I think I saw something in South Carolina that the prediction with the Affordable Health Care Act was that we're all going to see an increase of 61% in our health care insurance. That's not affordable, and that's the wrong way to go because we don't have choice. You have to get so much, and the insurance companies have to pay for this and that you might need or you might not need, but you're paying for somebody else, and guess what? The prices and costs go up. And the last thing that was really important with the healthcare reform that we wanted to see addressed was immigration reform. And again, this is an important issue because we spend so much money on unreimbursed health care by the illegal immigrants. And I can tell you stories from Spartanburg Regional Hospital that we see that cost thousands and hundreds of thousands of dollars, and we're not even close to the board, we're not a board hospital. So that was important to bring down the cost of health care. And all these points for health care reform were denied. They're nothing to do with the Affordable Health Care Act, so it's not what we want, and so we're frustrated for it. The big problems we have with the Affordable Health Care Act, not getting too much of it, but a couple of things. It cannot be cheaper by design. Costs will go up exponentially. When you pay for increased access, cover, utilization, people ability to go to ERs and physicians, more preventive health care services, it can't be cheaper. It can't be cheaper, so it's got to go up. The basic tenet, to go back to what Dr. Baker had said, of the health care plan is flawed. Giving somebody health care insurance, when there's a study done in Oregon that proves this, does not mean they become healthier. So what's the plan? Do you want people to be healthier and manage their health better, or do you just want to have everybody have basically free access to the healthcare providers? Well, we chose the latter, when actually, ideally, we would have a plan that would get everybody healthier, but that's not what we have. We give everybody health insurance, and the health of the nation is not going to improve, and that's been shown in the studies. And then probably the biggest problem is there are not enough doctors out there to meet the demand. They estimate in shorts about 25,000 primary care doctors, and I guarantee people are not going into primary care medicine right now. In fact, when you look at the numbers about 30 years ago, about 50+% of people graduating medical school were going to primary care. Now that number is between 8 and 10%. And why is that? Because we all have lots of debt. And when I'm sitting there thinking, well, what do I want to do? Do I want to see 40 patients a day and try to make my minimum payment to my loan company? Or do I want to do a couple of expensive procedures every week and have extra money? You know, to see what people are making a choice, and it's hard to fault them. They're going to the higher price, more lucrative subspecialty. But that's not what the healthcare system needs. So what are doctors doing besides being frustrated? Well, there's different strategies that are evolving, and there's maybe 4 or 5 things that you're seeing across the country that evolve. That's where the free market is reacting to these changes. Number one, doctors are getting out of the business. Doctors are retiring. Doctors are saying, I'm done with this. I'm a couple years shy of it. I can go work for an insurance company or something for a couple of years and make sure my 401k is properly filled, and then I can get out of this. So you're having doctors getting out of the business. You're having doctors closing their doors, and the amount of doctors going bankrupt right now is at its highest rate that I've ever seen on record. So those are 2 strategies, not good strategies. The next strategy is sell out to insurance or sell out to employers, becoming an employed physician, working for the hospital, and basically we stand back on the treadmill and we're doing the same thing, seeing lots and lots and lots of patients and doing what the employer tells us to do, but we don't have to worry about running the business at all. So that headache's gone. So there's good and bad to everything, but we're still basically doing what we didn't want to do. The other strategy that's coming out is what y'all are doing at Proactive, which is, it's called a disrupted practice or a fee for service. I don't know if you've heard that term, but basically this is a cost and that's what you pay. If you want that, you pay it. Otherwise, if you're not interested, you don't pay it. And there's a lot of benefit to that. The downside of it is that if you have insurance, then you have to bill insurance yourself. And then the last strategy that's coming forward is what's called this concierge model, although it's kind of like a hybrid. But basically, you're paying the physician and you're having access to the physician. He's deeply involved in preventative health care and doing proactive laboratories and testing and, hey, come walk me, let's go to the gym, and think of all these interesting things you can do that are very proactive for prevention. And numbers are coming out showing that when patients participate in that system, there might be a sample bias, but on average, compared to traditional Medicare patients, there's about a 70 to 80% reduction in hospitalizations. And then readmission rates is about 0.5%. So you go to the hospital and you have to get sick, you go back in, that happens only less than 1% of the time that people have these proactive physicians. And the nice thing about it from a physician standpoint is that now I'm beholden to the patient, which is who I really want to be beholden to. That's who I want to have that discussion with, and all the other wonderful doctors that you talked to today. Hopefully it was clear to me that they enjoy that patient interaction with and enjoy talking with the patient, trying to figure out what's going on, and fixing it with all our different modalities. But the clear winner is the patient, if we can all embrace those type of systems. But right now, that's the opposite direction of where we're going. So that's all I had to say. My papers are a mess over there, but I'm relinquished my. Appreciate your attention.